So welcome to the first COVID talk of 2022. And it's been 2 months since I did one of these due to various conflicts and preferring to watch playoff games instead of do COVID charts for a couple of weeks in January. So it's been 2 months. So you'll see a lot of the references will reference back to early December. Of course, a lot happened between early December and now, as you'll see in the charts. So it's just a little bit different cadence than it usually is. So I'll go through the normal sequence of things, mostly that this latest resurgence associated with Omicron caused a lot of issues fitting the model. I have spent a lot of time, instead of collating the data and the output of the models and putting them into charts, just working with the models to get them to fit properly. So as a result of that, there won't be California county models, individual county models summing up to a state model. The other models will all be there. Also, the special topic that I said I would do this time about vaccine safety and what are the real data regarding injuries or deaths associated with vaccines. I didn't have time to do that for this one, but it's on my list. So I will endeavor very much to do it next month because I think model fitting, unless something crazy happens, model fitting will be pretty smooth next month. So I'll go through the global regions and outbreaks like I usually do, the countries, some data on cases and deaths, which is interesting and is looking very different in terms of the relationship between cases and deaths for Omicron. U.S. state models for cases and deaths. For California, I just have a statewide model and then one for Santa Barbara and some updates on those. Updates on variants, a couple different versions of Omicron, and vaccine updates. Similar kinds of topics as usual. So in summary, as I assume is widely known, global daily cases really soared between the last time I did one of these and this time. So they got up to about 3.5 million cases a day. In early December, there were about 700,000 cases a day, which was already approaching a new record. So 3.5 million cases a day is almost over triple what they've been before. You'll see it in the graphs. And they've been declining over the last 2 weeks, and they're down to about 3 million cases a day. So still very elevated. And as we break it down by countries, you'll see there's plenty of examples of countries that aren't declining, but there are a lot that are. I have some data on the variant proportions, and you'll see just about everywhere Omicron has displaced Delta as the dominant variant, which was when we talked about it in December. It was looking like it was starting that way, but we didn't have the results yet. But it's very clear, and I'll show some data on that. Vaccinations continue to be administered, but the daily doses as a planet that are being administered are about half what they were in December. So vaccination rates are declining, and there certainly are places, particularly in Africa, where vaccination rates are really quite low still. So all these data come from Friday's download from Johns Hopkins. So these are data as of the 4th of February. And when we look at the March of the outbreaks chart, I think since December, it was just really right about coincident with the talk I gave last time the U.S. passed 50 million. So it was the first outbreak to accumulate 50 million confirmed cases. India may actually have that many based on serology, but in terms of confirmed by testing cases, the U.S. is the only one that's crossed 50 million. Similarly to what it's been for a long, long time, there's no new outbreaks showing up. It's about everywhere. No growth in the outbreaks of over 100 cases, which is kind of where, from way back when I started an outbreak, I defined what an outbreak is when it gets to be over 100 cases. There hasn't been much increase in the medium-sized outbreaks, so less than 5%, all the categories less than 500,000 in the last 2 months. But there have been significant growth, as one would expect during this surge, in outbreaks that grew to sizes in these larger sizes. So about 15% growth, plus or minus, among these categories. 500,000, 1 million, and 5 million, 30 to 60% growth in the 2 and 10 million. And this should say 20 million, but it says 29 in the last 30 days. So with all those cases that I mentioned in the beginning, outbreaks are going to be growing. In terms of which outbreaks have changed, so the UAE, Tunisia, and Nepal all dropped out of the top 50 as they haven't had a big resurgence. And 3 outbreaks that had previously been among the largest went back in, Australia and Ireland and Denmark. And Ireland and Denmark have been being moderately small countries in the sea of the outbreaks that is Europe. They've been in and out of the top 50. Australia, interestingly, had hardly been in there. Very early on, there were some outbreaks in Australia. They managed to keep that under control for a long time, and as you'll see, they're rocketing back. And so is South Korea. South Korea is another country that was one of the early places that COVID occurred and then managed it very well for a long time. They're 51st right now out of 50. So if this was one box longer, South Korea would be on there. And they're seeing significant case growth. So I expect that next month, South Korea will be back on this list again as well. And in terms of the regions, there hasn't been any huge change in the proportions of cases. Europe is about 50% of the daily new cases. By the UN definitions, Western and Southern Europe actually are a little bit down. Northern and Eastern Europe, in particular, Eastern Europe, as you'll see, has some very big resurgences. They're up. But overall, Europe is just under 50% of these cases. And a month ago and 2 months ago, they were in the mid-40s. So that hasn't changed a lot. North America remains about 15, which is similar. Latin America actually has come up a little bit in terms of their share of the cases. You can see this gray at the bottom here is East Asia. This is Japan, which after the Olympics passed through in July was back down pretty low, and they're not anymore. Here you can see the growth in Eastern Europe from a pretty small proportion back here in mid-December to a significant proportion. These different subsections of Europe seems overdivided for the UN to make Europe into 4 different regions. But when you do that, they're in aggregate about the same, but it's moving around among these regions. So moving into the country models, these are the R-squareds. They're very similar to what they have been. I'll mention it and point it out a couple times, but there is a characteristic of these Omicron surges is they're extremely steep. So the parameter in the model that defines how fast they grow and go down, it's the same parameter that defines both ends of it. Because of the way time is treated, the models is having difficulty actually fitting a peak sharp enough to fit these data. So the R-squareds for cases, you can see, are lower. Almost always the R-squareds for deaths, because there are fewer of them. And so it's noisier. The R-squareds for deaths are a little bit lower, but you can see the actual R-squareds for cases are trending lower in general than for deaths. So these are the 10 largest outbreaks by country and the cumulative total. And I think that the thing to notice here to see really the difference, it's much more obvious on the daily case graph, but there's some undulations in the overall progress of the pandemic. But all in all, it's not all that different than just than a steady growth in terms of the cumulative cases. And it goes up and down a little bit until we get here to mid-December. And the slope is just obviously very different and larger. And this represents the peak largely comprised of Omicron. And this is the way it looks on the daily new cases graph. This overshoot of the peak of the fitting of the models is a result of this problem, this limitation that I need to work on in the next month or so to improve it. But this limitation to run into some mathematical undefined, some parameters get undefined when the growth gets that high. And so I can't quite fit that sharp peak. But you can see it's a very, very sharp peak and a very, very large peak. These black dots in the dashed line you read over here. So this is 3.5 million cases a day, is this line here. And you can see we're down to about 3 million, at least we were on Friday. And that's the 7-day average of 3 million. And most of the large outbreaks you can see are peaking. Some haven't really peaked yet, or at least the model doesn't think so. The ones here with peaks a little bit in the future, but a lot of the big ones, and the US being one of them, has peaked and is heading down so far, it looks like. In terms of fatalities, it looks quite a bit different, right? This slope we don't see a real discontinuity and a change in slope like we do on the cases. It's really pretty steady growth, a little bit higher slope than it was early on, but case numbers are also much higher. But we don't see them turning up at the same way. And you'll see that throughout, at whatever level we look. county, state, country, planet. Fatalities are not going up in the same dramatic way that cases are, which is good. I'll talk more about that when we talk about Omicron, but fatalities are not keeping pace with cases, which is good. And these are the daily fatalities, and you can see the fatalities are increasing. We're having 3 million cases a day last week. Fatalities are increasing, but they remain significantly below 2/3 of what they were when we were having 1/3 as many cases. So they're still going up. They haven't peaked yet. It's not clear exactly where they'll peak, but it seems extremely unlikely they're going to peak at 3 or 3.5 times this number, which is the way cases peak. So fatalities are definitely different in this resurgence. So the 5 largest outbreaks have changed. So France has returned to the 5 largest outbreaks. It displaced Russia and actually passed UK by a little. There now are 2 in Europe, 1 in Latin America, 1 in South Asia, and of course us in North America, that make up the 5 largest outbreaks. And you can see there's a similar kind of a pattern in terms of having a very sharp peak. It peaks in early to late January, depending on which country, and is now declining. India never reached their previous record, which is interesting. Most countries, you can see Brazil now, they were delayed really in getting their Omicron peak starting. They may have peaked, they may be peaking, they may not. It's a little bit too early to tell. But you can see they're at some multiple of their previous record. France is at a significant multiple. The UK, everybody's seeing far more cases, except India. India looks like they peaked at a level a little below, call it similar to their previous record, which was in the early days of Delta that surge occurred. And everybody seems to be going down in terms of daily new cases, except Brazil. Can't see that yet. And then the UK had some funny business with their data a little bit. They had a aberrant, well, hopefully it's just an aberrant data point up here at a new peak after it sure looked like they were coming down. So we'll have to see as more data come in if that was just one of these data snafus or if it's something real. And as I've mentioned a couple times, picture those new case records 3 times as high as they've been, and then now coming down for the most part. We don't see that at all in fatalities. So here's the US. Our fatalities are increasing. Doesn't look like they've peaked yet, but certainly the model isn't fitting them to reach the level of daily fatalities that we saw last January. So during the peak a year ago, the model is expecting that we won't achieve that level of daily fatalities, even though we'll have 3.5 times as many daily cases at the peak cases. India's going up. It's a little hard to know where they'll peak. Brazil is also going up. The European countries remaining significantly below where they were at their high daily fatalities. So all these things, and I'll keep pointing it out in the data, all these things I think support the initial indications that Omicron is generally milder. You're less likely to die from getting Omicron. Of course, on top of this, you have to map the fact that now a significant fraction, over 2/3 of the world, is vaccinated, which has a dramatic reduction in people's risk to die from COVID. But even in July, September, we had not a very different level of vaccination, but what looks like it's going to be a significant difference in case fatality risk in the US, for example. So in the rest of Western Europe, there are signs of peaking in a lot of places. Italy, Spain is definitely down to about half, and not quite yet in some places like Germany and the Netherlands. And you can see this in a lot of places when you look at individual countries in a region. Many places have peaked and are declining. Some places have not peaked. And those are 2 examples among the largest outbreaks in Western and Southern Europe. Eastern Europe seems to be a little behind in the timeline in terms of going through their Omicron peaks. Particularly Russia appears to be just starting, and they're seeing cases not dissimilar to the kinds of things we saw here, where they're seeing 3 times as many new cases a day as they have ever seen in the course of the pandemic. And that started a little later. It started in January instead of December, like a lot of other places. As I always say, when you can see these X's and you see them getting farther apart, you're not inflected yet. Russia appears to have a ways to go before they peak. Poland may be peaking. This cluster of points very near to each other may represent a peak. The model isn't fitting it that way. It is expecting them to continue to go up a little bit. When I talk about variants, Poland is the one place that has the most prevalence of the third version of Omicron, BA.3. It'll be interesting to keep an eye on Poland just to see if there's any significant difference in that behavior, because it is a significant part of their overall variant distribution. It's about the only place with a big outbreak that's like that. Ukraine is still going up, Czechia, Romania, Slovakia, pretty much across Eastern Europe, with a couple exceptions of places that have peaked and are going down. They're still going up in daily new cases. That was in that regional graph. You could kind of see that. A lot of places in Western Europe are starting to come down, right as places in Eastern Europe are starting to come up, and overall Europe is still about half the daily new cases. Latin America, Brazil was going up quite rapidly. Chile also, which is interesting. Chile is a very vaccinated country, about the most vaccinated country in South America, reinforces that the efficacy of the vaccine is, in terms of avoiding contracting COVID, is compromised by Omicron. It's not eliminated, but it's reduced. That variant is dominant in Chile, just like everywhere else. They're seeing significant growth in cases. For the most part, the rest of Latin America seems to be at the crest or coming down from the crest of their Omicron wave. In Central and Western Asia, also, I would group this in the getting their Omicron surge a little bit later than many other places. Turkey is now up at, if you exclude their data issue where they had 800,000 cases in a day by fixing their data, this is a new peak for Turkey. Iran was an early place that had an early outbreak and has kind of bounced around many times in the pandemic, is now surging back up. They haven't quite reached their previous high, but looking at how far apart these X's are, they will. Iraq is going back up after having remained really pretty low all the way throughout 2021. And then Kazakhstan, there's been data noise challenges in Kazakhstan in both cases and deaths. A little hard to tell what's going on. The model thinks they're about to peak, but it's a little early to say that, I think. South Asia, Nepal is out of the top 50, so I don't have a model for them running anymore. So that's why this used to be 3 graphs. This chart now is just Bangladesh and Pakistan. And they both have seen resurgences, and really similar to India, across South Asia, we haven't seen yet peaks that are a multiple of the previous peaks. They're on the same order as the previous peaks. I have no idea why that is. It's just an interesting difference between South Asia and most of the rest of the world. So both Bangladesh and Pakistan look like they're peaking, and they're peaking in the neighborhood of where they peaked before in the late summer, early fall. North Africa and the Middle East, of course, we had a couple outbreaks. Tunisia and UAE fall out of the top 50, so there are just 3 outbreaks in that region. Israel, also a very vaccinated country, is having quite a big surge this year in this most recent resurgence. Jordan also hasn't peaked at all. Morocco appears to be down. They're down, coming close to a third of where they had peaked in January. And unlike the other countries here, they never exceeded their previous peak, whereas both Jordan and Israel are ending up at a multiple of where they had been before. In Southeast Asia, it's a little bit hard to tell. The Philippines definitely had a significant Omicron surge and are coming down now. Indonesia looks like it's just starting one. You can kind of see that here in Malaysia and Thailand as well. Vietnam, I'm not sure what's going on in Vietnam. This peak that started too early to assign to Omicron, and it's very noisy in here, so I'm not sure what's going on with Vietnam. But cases are coming down lately, but it's not clear that they've kind of gotten through their Omicron peak yet or not. It seems like Malaysia and Thailand may be just starting theirs. Couple other outbreaks of interest. South Africa, of course, where Omicron was almost first detected. It was either South Africa or Botswana. They are down a lot from their peak, so they're not surprisingly about one of the first countries to get through their peak and down under 15% of where they were at their peak. They have a very pronounced surge, and then little cases, then a big surge in little cases, more than many other outbreaks. I'm also not sure what the explanation for that is. This is Japan. It's hard for me to keep the right perspective on this. Before this surge that's happening now, this surge that happened starting in July around the Olympics, looked enormous. It was dramatically different than anything else we'd seen in Japan. And now this one that has started here just in January is really dwarfing that one. Japan is the largest cause of why East Asia is starting to show up again on the regional graph. Here's Canada. As often it does, it looks similar to the U.S. in that there was a big peak much higher than before, and it's down now. It's down a little bit more than we are in the U.S. Here's Australia. Again, you have the same scale issue you have with Japan, that there actually are outbreaks in here, but they're so small compared to what they have just had that it's hard to pick them up. But it's this very large resurgence that had them back in my set of global models. Cuba had a relatively small surge. They don't report to GISAID their variant surveillance. If they do it, I don't know that they do it. At any rate, it's not in the database that I access for that. So I don't know if this is an Omicron peak or another peak, but it's a relatively small peak and is now declining. Sweden, like many other places, and Denmark is another one. Several places in Northern Europe are seeing resurgences that have yet to really start declining, and Sweden is the largest of those. Okay, moving on to the state models. These, of course, are also from Friday. Still have the same models for countries change around as countries become more significant or less. But for states, it's just always the 50 states plus Washington. And the sum of the states models predicts about 110 million cases for the U.S. and about 1.1 million deaths. So that's a 1% CFR versus what it is actually right now. I mean, if you just take the total cases and the total fatalities, it's about 1.2%, which is lower than it was in December. So in general trends, the case prediction is about double where it was in early December, but the death prediction is only about 30% higher. It was 850,000 the last time in early December. Now it's 1.1 million. So it's a significantly smaller increase in predicted fatalities than in predicted cases. And as you'll see in the individual states data, most states are beginning to see declines. Not all of them, but most of them. Individual country model predicts about 90 million cases and 1.3 million deaths. So similar kinds of numbers, a little bit higher CFR for the individual country model. Put it into perspective, about 6%, so 19 million people of the U.S. population have been confirmed as a case in the last month. So that's about 8 times what it was in November and about 4 times what it was in December. So January was the month of lots of cases. So this is the country model, and again, you can see it's similar. It's not quite as linear in the run-up to this most recent resurgence as it is in the global model, but you can see this slope is higher than it's been previously, and many of the cumulative totals are starting to become concave downward as resurgences peak in these states. And this is the way that the daily case graph looks. We went from previously having a maximum of 250,000, 275,000 cases a day to where we, in a 7-day average, reached about 800,000 cases a day. Big increase in cases. This is California, this kind of brownish one here, the rest of the top 10 states. This one that's a little bit goofy is Michigan. Between some surging and some data issues, the model's fitting that as a different kind of surge. But I expect as it settles out, it'll start going down relatively soon. These are fatalities. You can see this is a little bit concave upward, which means it's increasing. A little hard to see much of what's going on here, but in the daily fatalities, you can see it a lot better. The prediction for the sum of the states models, is the fatalities will peak below where they were last January in early March, roughly. And they'll, again, peak at a level below what we've seen before in spite of the huge number of cases. Most of the states are on the verge of or starting to show signs of peaking here in the next few weeks in fatalities, which is what we'd expect. The cases peaked a couple weeks ago, and the peaks in fatalities usually come 3 or 4 weeks after the peak in cases. So looking at in the U.S., where is it happening the most? Well, we're at the top of the list here in California. We represented over the last 14 days 16% of the new cases in the country, which is more than our share. It's So we haven't been on this list bold in red, which means we're contributing more than our share of new cases. We have about 12% of the population and represented about 16% of the cases. Next was Texas and Florida, which were both, Florida actually a little bit lower, Texas about consistent with what you'd expect based on their share of the population. And then the next four, North Carolina, Tennessee, Washington, and Arizona, all are seeing cases disproportionate to their population, excess contribution to the cases. I've been doing this with 7 states. I mean, for a while I was doing it with 3 states because there were just 3 that represented such a big fraction. These 7 states are a little bit less than half the new cases. They represent a little bit more than a third of the population. So they're contributing more cases than you'd expect based on population, but it's not the dramatic difference that it was earlier in the pandemic, where as the pandemic was moving around, it still remains pretty broadly distributed in the U.S. So where is it happening the most and the least per capita? So where is the most intense community transmission? The 5 with the most new cases per 10,000 in the period from January 21st to February 4th are Alaska, Tennessee, Kentucky, Oklahoma, and West Virginia. There's some little bit of regional clustering, maybe. I don't know. It's a little not as clear as it has been in some of the other graphs. And the fewest, though, is pretty regionally concentrated. So the fewest new cases per 10,000 have been Maryland, D.C., New Jersey, New York, and Connecticut. So pretty much where you can drive on I-95 north of Virginia is where there's the lowest per capita new cases. This map on the bottom, these are just, of course, 5 each, but these are the top and bottom 10 in terms of who's had the least new cases per capita and who's had the most. So as the top 5 were, all these low per capita new cases are clustered in the mid-Atlantic and Northeast, certainly on the northeast quadrant of the U.S. The places with the highest levels of community transmission and per capita new cases are really pretty spread around. It's hard to convince myself there's really much of a pattern here. I mean, certainly Kentucky and Tennessee and West Virginia are all contiguous, as are North Dakota and Montana. But really, it's spread pretty much all over the place where these outbreaks are still pretty strong in terms of per capita new cases. The graphs on the right, if you look at the overall trends, they look pretty similar. So most of these big outbreaks are peaking. Maybe not Tennessee. Question a little bit. Maybe Washington hasn't really peaked yet, or at least there isn't strong evidence it has. There's definitely decline in the daily new cases. And when we look broadly across the U.S., this map that I do every time, orange is where the state experienced more cases in the last 7 days than they had in the previous 7 days. And red is where there's a new all-time high in daily cases in the last week. So for the week that just ended, 23 states had more cases in the last week than the week before. In December, it was 41. And actually, if I'd given a talk in January, it would have been 50. And it would have been 40-some red for reaching new peaks. But I didn't give a talk in January. So now in early February, it looks like this. So 23 states still seeing week over week increases in cases, and 4 of them, which is actually the same number as in December, hit new peaks in the last 2 weeks. It's interesting that Maine is red in both of these graphs, but they are. This is one new source of data, and I haven't really gotten into the numbers of the data and tried to make some inferences, but these are just the maps that the CDC publishes. So many health departments, I don't know whether we do here in Santa Barbara, I would think so, but I don't know. I haven't seen the data. But many health departments test sewer outflow, and it's viewed as a bit of a leading indicator to test results, as people will begin shedding the virus in their excrement ahead of the time they develop symptoms and get tested. Or it's actually a pretty interesting and useful way to monitor populations rather than individuals. So there are 2 maps that are published. One is the 15-day percent detection, where red is 80 to 100% of the samples collected were positive for COVID. And you can see that just about everywhere is red. There were some 4 places where it was between 60 and 80%, it's surprising that there were that many. So COVID is pretty much everywhere, which we can see from all the graphs so far. The more interesting one is the 15-day percent change. So this is the level of virus that's being seen between now compared to 15 days ago. And the blue colored dots are ones where it's declining. They range from the light blue is about a 10% decrease, and the medium blue is up to 100% decrease. I'm not sure how to interpret the top category, minus 100% or less. I don't know how it becomes less. I would expect that means basically none compared to before. But you can see that most of the dots are actually gray, which is no data reported. But of the dots that are colored, most of them are blue. And you can see on the tally that the single largest category is in this greater than a 10% decrease. And that's consistent with what we see with the graphs of cases, but this actually, is a leading indicator of that. So in about 75% of the reporting sites, it's trending down. So as I mentioned, no California county models this month. I just have a couple charts to sort of summarize what's happening in California. So this is the larger version of the California state graphs that I showed before. So cases, soared up to about triple where they had been before, a little less than triple. And they're now down to almost a third of where they were at their maximum. So it definitely seems that cases are coming down in California, and we'll see Santa Barbara as well. Fatalities don't look like they've peaked yet, but doesn't look like they'll peak even as high as they were last January, in spite of the large number of cases. So the state model now predicts about 11 million cases and about 100,000 deaths. And not unlike the global and the US predictions, this is about doubled since December, and deaths are up about 25%. So much bigger increase in predicted cases than predicted fatalities. They have been declining for 2 weeks, a little over 2 weeks now in California. The model case fatality risk is 0.8% versus it's 0.9% right now, which is below where it's been after not changing for pretty much most of 2021. It's now dropping, which again, I think is evidence of Omicron's lower fatality risk. If I look at the case fatality risk estimated for the fatalities we've had in the last month compared to how many cases did we have in the 3 weeks offset time. So accounting for that 3-week lag, not counting the cases in the last 3 weeks because those probably haven't turned into fatalities yet. And then starting 3 weeks before a month ago when I started counting fatalities, that number is only 0.2%, which is really dramatically lower than it has been. And I think, it's the overall case fatality risk is an aggregate. So it's not going to go down as much as a cohort will, because you've got all the millions of cases and tens of thousands of fatalities we've had before this that reduce the effect of the lower case fatality risk now. But if we just look at that most recent 30 days fatalities and the cohort of cases from which they likely came, that case fatality risk estimate is about 0.2%. I don't know if it's really that low. Oftentimes, those estimates are off when everything settles out, but it does seem to be, it's different than it has been. I don't know if it's that low, but it's definitely different. In Santa Barbara County, we reached a new peak in January, up the middle, a little bit past the middle of January. And we crested a little bit over 1,000 cases, up to about 1,100 cases a day, where we previously maxed out at about 500. So not unlike many other places, about double our previous record. Daily deaths have increased over the recent period. And this really looks a lot like the overall California or US graph. Daily deaths are increasing. The model isn't fitting to that little tail coming up on the deaths yet, but it's headed up towards 3, whereas when we look at where we were last winter, at the end of January, beginning of February, it was coming up about 6. So we have again, similar behavior in terms of the relationship between cases and deaths. Hospitalizations show a similar pattern. So this box here is hospitalizations. The hospitalizations peaked at about 150 in the middle of January in Santa Barbara County, whereas in last January, they exceeded 200. So in spite of the larger number of cases, there are fewer hospitalizations. It's about 3/4 of the level we reached last January. Our case fatality risk is about 0.8%, which is significantly declined from 1.2% where it was most of 2021. So we've got a lot more cases and a proportionally fewer number of fatalities, although they are going up still. They aren't starting to come down yet. Testing positivity is still really high, higher than it's ever been. It's throughout January and even the last week in January, which are as late as these data go. It's been 15 to 20% positive cases. So testing positivity remains pretty high. New cases are coming down. The other thing that's different, there were 66 new cases in the prison. So since January, that's the first cases they've had in the prison since May of last year. So they went a long, long time without any new cases, and there have been 66 during this resurgence. But they managed to get through the community surge we saw last summer without having a single case in the prison, but that didn't happen here in December and January. So moving into variants. So this is an update to the graph I routinely show on the mutation rate and overall time versus number of mutations colored by clade of the different phylogeny of the variants. So this Omicron up here, this darker orange is 21K Omicron. This lighter orange is 21L. Those are the next strain clades. It's just the year that they first show up, and then sequentially they add a letter to it. So it happened, first found in 2021, and first one was K and the next one is L. L is this lighter orange here as well. These two are Omicron. It's gaining a little bit on Omicron BA.1. This is BA.2. It's still relatively small compared to the first version of Omicron. But between the two of them, they made up about 78% of the global sequences as of January 22nd. So these lag a little bit. We'll see the CDC data from a little later than that. Delta is about 21%, basically the rest of the global cases, and declining. So it's been very successful, obviously, as we've seen in all these graphs, in displacing Delta and resulting in large resurgences, but much smaller increases in fatalities are being observed. So there are at least two flavors of Omicron, as I mentioned, BA.1 and BA.2. There's also a BA.3 that is we're seeing in Poland mostly. Don't really know anything about it yet, except it got another Pango designation. It hasn't gotten a next strain clade yet. It would be 21M. And it has, as I mentioned last time, significantly more spike protein mutations, about 4 times as many as Delta. And a lot of these are in the areas of the spike protein that interact with things like cells and antibodies. The characteristic to which it's very significantly different behaviors attributed. 21L, the BA.2 newer version of Omicron, has a slightly fewer number of mutations than Omicron 21K, 5 fewer spike protein mutations, but still, in this markedly displaced level of mutation from all the other variants previously that gives it a very different behavior. And I think we almost need to think of this as, it's a very different kind of COVID. Almost think of it as a different disease. The efficacy of vaccines in terms of transmission is lower. Certainly in terms of avoiding severe disease seems to be just about as good, but it certainly isn't as virulent as the previous versions of COVID. These are a couple graphs of the variant evolution by country. These are from NextStrain, which is a site that analyzes the GISAID database. Most countries look similar to the US and the UK. Like we saw when Delta came, there was just the right side of every graph was green because Delta had displaced everything else. Now the right side of every graph is pretty much purple because Omicron has done that. I included India and Denmark because they're notable in the degree to which BA.2 or 21L has displaced 21K. That's the lighter purple margins here. You can see a little bit of it. It may be hard to see, but this topmost right-hand corner of the US is light purple, a little bit more in the UK. But Denmark and India are two places where it really has become a significant fraction and where it seems to be displacing 21K. And it may, when we saw with these various versions of Delta, here, this top little sliver here is also Delta, but three variations of Delta. One of them eventually was the one that became dominant. This is 21J Delta. But at any rate, we'll see. I haven't read anything or seen any data that 21L is different or not. I just haven't seen a real description of what may be different about it in terms of the course of its disease, but it's at least distinguishable from sequencing. It's also distinguishable. One of the features of Omicron was that you could tell just from a standard PCR test if it was an Omicron, because some of the mutations changed the way that the readout of the PCR test looked. It would be positive for COVID, but there would be characteristics of Omicron. You wouldn't have to actually go through and sequence the virus to determine the variant strain. But with 21L, those mutations are missing. So it looks like all the other COVID variants, and you don't get that sort of free variant identification that you do with 21K. This is the variant proportion graph in the US from the CDC. So this nowcast that's noted here is a modeled prediction because they know they don't have all the numbers in yet for the actual prevalence. And at least looking at the Omicron progression, the model is forecasting that Omicron's going to have more share than it ends up having when all the data come in. So, this, remember here, even in December, the nowcast was saying it was 90% Omicron, and it's still a lot of Omicron, but it's 75% instead of 90%. These are the real data here from the middle of January, and that's more than 95% Omicron. So Omicron is the dominant strain in the US, certainly, and in California. This is looking at it by regions. It's Omicron is the flavor of COVID that's going around now. And the same is true in Santa Barbara County. So we've detected, over the course of the pandemic, almost all the different variants. And if we look at what's been sequenced so far in January, it's only about 75 sequences that have been returned for January, but they're almost all Omicron. So it appears to be the dominant variant in Santa Barbara, just like the rest of the US. If I look at the number of sequences, a couple observations, certainly in December, the number of variants sequenced or the number of samples sequenced went up compared to November and October, and it's likely to still go up, and certainly January will go up significantly as well. But one thing as I was making this chart, I have the chart from last December that I start with, and then I move new graphs in and stuff. The Public Health Department in December of 2021 the count for January of 2021 was 550. And now it's 750, which would imply that 200 new sequences were reported from January of 2021 a year later, basically. So, and that happened in the several months throughout 2021. But the biggest notable thing was it last January. So I'm not sure if that was retained samples, if they went back and sequenced, or why that happened. But it's just a caveat to all these data that accounts continue to increase back in the past and can, so far not significantly, but potentially can alter our understanding of what the variant proportions were in that period as new information comes in months later. But the bottom line right now, all the data suggests that we're in the same variant pool as everybody else, and it's Omicron. All right, a couple charts on vaccines, and then we'll be done here. So this is an update to the list of countries, mostly large countries, but trying to look in a broad way across regions and development levels. And UAE remains up near the top. The US, is up here at the bottom of the top quartile, I'd say. And the world is this gray one with these little steps in it that happen when China reports kind of erratically. So there's a large disparity between countries still. Of course, this is Ethiopia and Nigeria, which are both lagging way behind the rest of the world. And about 10% of the people in low-income countries have received a dose. And that's, not up that dramatically. It was 6% in December, and now it's 10%. So it's better, but it's not dramatically better. Global vaccine delivery has fallen to about 18 million doses a day from December, when it was about 35 million doses a day. So it's gone in half in the last month and a half or so. And in August, it was over 40 million a day. So the rate at which vaccines are being delivered globally is declining, but 61% of everybody has received at least a dose. So that's up about 6% from December, and it's getting really close to 5 billion people. It's about 4.8 billion people that have been vaccinated to some level. So the delivery is continuing and slowing. And places, you can understand well, a lot of the U.S. people who can be talked into having a vaccine, a lot of them have been vaccinated, and it may not go up a lot more. That's true of a lot of places, but there are a lot of places also that are very much lagging, some of whom have very significant outbreaks. And so it's a little disappointing that the delivery is dropped so much, less than half of where it was in August. A couple more views of vaccination rates. So this map is colored by doses administered per 100 people. So you can see China is pretty green, Canada's very green. This is Chile over here, if you remember from, a couple hours ago when I was talking about Chile's graph. They're having a big resurgence that isn't peaking yet, and yet they're among the few places that are really very green. So is Cuba, UAE down here, China, and then most of Europe and North America and the rest of Latin America is pretty green. Vaccine has been pretty effectively distributed. Africa is clearly the place with the biggest gap. Russia, to some degree, is under-vaccinated, and they're certainly seeing a big surge. This was also an interesting graph, I thought, which was, okay, that's what fraction is vaccinated, or how many doses per 100 people, or these per capita kind of measures. Where are the unvaccinated people by the millions? Where are the most numbers of unvaccinated people? And it's maybe a little bit misleading, but they're, there's a lot in Africa. There are a number in the most populous countries, just because we're starting with a very big number and multiplying it by some fraction that's unvaccinated, we still have a pretty big number. The US, China, and India as the three most populous countries are here. Russia, which as I just mentioned, and you can see from this graph, is not very vaccinated. Pretty populous, about 2/3 of the US, but less vaccinated, so they're pretty dark red. But that's where the millions of people that are still more vulnerable to getting severely ill or dying if they contract COVID are here among those countries and in Africa. For the U.S., the vaccination delivery by state and then the daily doses administered. So this is the percent of this map on the left is the percent of the population receiving at least one dose. These are CDC data. And you can see up here in this New England cluster is very high degree of vaccination. DC, Puerto Rico actually also has gone way up in vaccination over the last couple months and is a quite highly vaccinated population. The low places, Idaho and Wyoming, Louisiana and Mississippi, more of the Southeast and Midwest, and then these relatively high numbers, the rest of the Northeast, California. So in terms of how we're doing delivering doses, it peaked last year quite a while ago, went down all the way till the summer, and then we started having cases resurge and vaccination rates picked up again. But really since December, they've been falling, and they're down to about 0.2 doses per 100 people per day, whereas they were up over 1 last spring. And, just like the global pattern, daily doses are declining. The range among the states has continued to increase, so now it's about 15-1 when you compare. I think Alaska has the lowest dose per capita per day, and New Jersey has the highest. Actually, Puerto Rico has the highest, but among the contiguous 50 U.S. states I monitor, New Jersey had the highest, and the ratio of that is about 30 to 0.2. So it's about a 15-1 ratio between those states in terms of vaccination rates, which is a pretty big range, in my opinion. And it's about doubled since December when it was about 6-1. So overall, 76% of us have received at least one dose, and about 64% are fully vaccinated. So, about 3/4 have some degree of have any degree of vaccination, and about 2/3 are fully vaccinated. 95% of those 65 and older have received at least one dose, and about 88% are fully vaccinated. So in that most vulnerable group, vaccination delivery is much greater than it has been. I should say the unvaccinated elderly is a lot smaller fraction than in the population overall. And CDC did fix this. If you remember, this said over 99% in December, which I actually footnoted because it couldn't possibly be true. And they fixed it. I'm not sure what happened. They didn't explain it. They just fixed it, and it's now 95% have been vaccinated. In Santa Barbara, these are the case rates versus vaccination. This is a very good graph that the Public Health Department publishes. So the gray line is overall, the blue line is vaccinated part of the population, and the orange line is the unvaccinated part. So it's a little hard to tell, but pretty much all through here, the ratio, the case rate in terms of unvaccinated population was about 4 times as high as it was for the vaccinated population. And it's fallen a little bit, but I actually would have expected it to have fallen a little bit more. But as Omicron comes through, and we know the vaccines are a little bit less effective at preventing you from catching it, it's only fallen to about 3x So from 4X to 3X. So you're still, even in the face of Omicron and the big surge that includes a lot of breakthrough cases, it's still, you're much more likely to catch it if you have not been vaccinated. At least, certainly in Santa Barbara County, that has proven to be true. And our vaccination progress isn't that different than the U.S. I think we are different in that our doses delivered hasn't fallen to a new low like it has in the U.S. in places. So we're still, we're about where we were in November. We peaked in December at about 2,100 doses a day. And in November and January, we're around 1,600 doses a day. 75% of our population has been vaccinated. It's, no, I didn't change this. These should say December. But 75% of the population is vaccinated, 67% fully vaccinated. So not that much different than the U.S. overall. Remember, that was about 3/4 and 2/3. So we're average. 79% of the eligible are vaccinated, and that's a bit of tracking that number is a little different because the eligible population changed not long ago when the younger people became eligible, but that's up. The first time I reported it actually had gone down because the population got bigger faster than the number of vaccinations got bigger, but now it's up since December by about 5%. 67% of the eligible are fully vaccinated. And of course, all those kids that became eligible have to wait for their second dose before they're fully vaccinated. So that's only up about 1%. But that delivery is happening. Still, just like in the US, the level of vaccination is higher in the elderly population. You can see here the over 65 group is both that, and the over 75 group is where the highest degree of vaccination has happened. Really, pretty much, people over 50 are in the neighborhood of 90 to 95% vaccinated here, and then it falls off as you get younger. So that's the data part of it. So kind of concluding comments. For the current outbreaks, the model estimates about 600 million cases and 7.5 million deaths for globally, which works out to about a 1.2% case fatality risk. The current value is 1.5, and really throughout almost all of 2021, it was 2. So this is more evidence of this lowered case fatality risk associated with Omicron. The case forecast has doubled. So, wherever we look at it, Earth, the US, California, the case forecast has about doubled since early December. And the fatality forecast is up about 25%. So, and again, whatever level we look at it, it's 25 or 30% higher fatalities being predicted. So, and that, as all this caveat's always in here, that the model is really just looking at the current outbreaks, and it can't predict if there's going to be a new one. And for the most part, countries, states, counties are peaking, and many are declining. For quite a few outbreaks, that's not true. Russia, Japan, Israel. I'm trying to think of one in each region, but certainly each region has outbreaks for which that's not true. But there are more declining than there are going up right now. After remaining steady really pretty much throughout 2021, the case fatality risk has declined significantly, consistent with the lessened disease severity, as well as vaccination having an impact. So I'm not sure how to parse those two impacts, but the new variant and the continuing increase in the degree of vaccination of the population are likely what's causing that case fatality risk to go down. That's my story for this month. So if anybody has any questions, I'd be happy to answer them.
Dave, I wanted to share a little bit about my story. My 64th birthday was January 11th, and our daughter bought me tickets to go with her to a concert at the LA Forum on January 15th. And so we went on the 15th. Everyone had to be fully vaccinated. I'm vaccinated. I was boosted in late October. Had a KF94 mask, which I wore the whole time. And I'd say everybody there had masks going in, but once they got into the LA Forum, people, probably 80% of the 80% of the seats were taken. 80% of the people were not wearing masks. They took their masks off. They're standing, they're singing along and cheering and whooping and hollering. And I kept mine on very carefully. And then that was on the 15th, which was a Saturday. And then by Tuesday, I was hypervigilant about symptoms, and I started noticing a scratchy throat and a little bit of a difficulty clearing my throat. Symptoms were gone by Thursday night, but then I did test positive on the home test. There's my home test. If you, I'm sure you're all familiar with it, but when you do these tests, if the C shows up, that's control, the line on C, that means the test is working as expected. And then if the T line shows up, that means you're positive. Then I did the PCR test the next morning. Yes, I was positive. No symptoms, but even a week later on the 29th, I was still testing positive on the at-home test, and it wasn't until February 3rd that I had a clean test. So, I mean, that was my experience. I don't know if it was Omicron, but I assume so. But when we peaked on the 19th, that little peak at the top, that top point, that was me. So, just wanted to share my experience.
Yep, this California here, this is right around January 15th. This is very tippy top. So, yeah. Timing was impeccable.
Yeah, sorry about that, everybody. I went to LA and brought it back.
I have one thing quick to share. So my friend is a nurse in San Francisco, and she has been struggling with her patients who don't want to get vaccinated. And she had a breakthrough recently where if she offers them a doctor's note that they can get a couple days off work, they'll get vaccinated. So we should, spread the word that people can be bribed if we choose to take that path, which I don't mind. Compensate, like whatever it is, yeah.
Now, is Tim sick? Tim looks, or is he just tired?
He's just resting.
Oh, okay.
Sometimes gravity is too much over here, so.
All right. That's a good tip, Dawn. Bribe people to get vaccinated.
Question about the semantics. When you say fully vaccinated to me means fully vaccinated plus your booster. And also, if you are immunocompromised, fully vaccinated means 3 shots rather than 2. So I don't know if the statistics take that into account or if it just means 2 vaccines.
Yeah, so the way they're reported, that's pointed out, fully vaccinated is 2 doses of the 2-dose vaccines. And then there's another category that's boosted. So fully vaccinated is not necessarily boosted. You're right.
I wondered if if there's been a difference in outcomes for states like Texas and Florida, where their governors were counter to the vaccine efforts. Has that led to a difference in mortality rate?
Yeah, so I don't know. I can't attribute it necessarily to the governors, but when I didn't do it this month, but in previous months, I've regressed the degree of vaccination in a state versus the mortality rate in the state, and the correlation is significant. So the lower the degree to which the population is vaccinated, the higher the case fatality risk. So there's definitely, as you'd expect, if the state is overall the population is less vaccinated, more of those folks are likely to die from getting COVID than if they were more vaccinated. So that's clear in the data.
I'm surprised I don't see stories in the media, commenting on that. And I was given a website early on in the pandemic that actually mapped case rate and mortality rate by red state versus blue state. And it was very interesting.
Yeah. Yeah.
Have you seen that?
I have. I've seen a couple people pointed out to me that how, especially kind of in the middle of the pandemic, you could really just parse it out by red state and blue state. It was like two different pandemics. Yeah.
Yeah.
I wonder if that'll change the voting.
Yeah. I don't know.
The other thing I read that of the people who die, 90% of them are not vaccinated. I don't know if that correlates with what your statistics show.
Yeah. That's all the data I've seen are in that neighborhood. Yeah.
So if they're not getting vaccinated in the Republican states, that might change the election, hopefully.
Yes.
Less voters?
We have some questions in the chat. She says, what is the long-term strategy for the immunocompromised? And a second question, do you predict or is it possible or likely that COVID variants will adapt to be contagious via surfaces, the way other common diseases are contagious via surfaces, and like how it was feared in the beginning?
They're great questions for somebody more familiar with infectious diseases than me. But so I'm not sure about surfaces and why this, because I think from the studies I've read, we thought it was going to be important to clean surfaces, and it turns out it really didn't make much of a difference from my interpretation of the data. So why this was different, I don't know. I think what was the first part of the question?
The immunocompromised.
Oh.
Strategy for the immunocompromised for vaccination or whatever.
Yeah. Yeah, it'll be interesting to see how this ends. It seems to me like it's heading toward ending. When I look at other pandemics, it seems that as things evolve, in terms of variants, they become more contagious, and that's how they end up being the variant. But that often for respiratory diseases comes with being less virulent, less, being mostly in the upper part of respiratory, where it's easy to transmit, but it doesn't cause quite a severe disease. And so whether, as this continues, becomes endemic, and does, like people said in the beginning, become not that different than the flu, if it ever does, then maybe we'll have COVID shots with our flu shots based on what's going around. But to me, it sure feels like the Omicron change really, shifted us to kind of a different phase where it's around, almost everybody's had it. Well, I can't say almost everybody's had it, but
you didn't catch it from me, so.
I didn't get it. Yeah, I haven't had it, but the seroprevalence of if I had more time, I would have put data in there on this. But the seroprevalence they measure, from blood samples. Like when I get blood, they measure me for antibodies, and they measure antibodies from the spike protein, which are there whether you're vaccinated or haven't been infected. But they also measure antibodies to the nucleocapsid protein, which is only there if you've been infected. So they can sort out and see, and see which is antibodies due to infection, which is antibodies due to vaccination. And it's pretty close to double. So about double the number of people that have been reported of a case have actually been exposed enough to develop antibodies to the nucleocapsid proteins. And, cases are likely to double again. And if we end up in the 100+ million cases, which I think is probably around where we'll end up after this latest surge is all over, that would imply that, between vaccination and having been exposed, that it's really quite a significant fraction of the population. So, so I'm not sure exactly what the long-term strategy will be for the immunocompromised, but it just seems like we're getting into a different phase where coexistence may not be so impactful as it has been throughout this whole time.
Yeah, Crystal is saying that her 7-year-old tested positive for COVID with a home test kit on Christmas Eve, and the only place he had been was to the COVID vaccination clinic, and they had it confirmed with official testing, and then her 4-year-old caught it, and she caught it with a home test a few days later that was detected. But they didn't go back in for a PCR testing. So what do you think the availability of home testing is doing to the official numbers and the CFR?
Yeah, so I have been thinking about what is the impact of home testing, because those numbers, if somebody just gets a home test and isolates for 10 days and then goes back in the world, they're never going to show up in my graphs, because unless people go out of their way to report at the public health department, it doesn't become a confirmed case. So it's likely that the underreporting that was about 2 to 1 in terms of confirmed cases to at least actual exposures, maybe not actual cases, that number will, seems like it should rise because of that. Inability to catch people that are just home tested, and that the home testing is very wide now. So,
Oh yeah, I got 3 of them right here. So, I didn't call into anybody. And then Sarah had a follow-up question about what are the best sources for data or studies, guidance for immunocompromised people. Have you run into anything about that?
I haven't. In terms of where I usually go is the CDC will have links to papers. I don't know, maybe there are a couple other sites whose names are escaping me that have peer-reviewed papers about studies with COVID of all different kinds of things that I look at for information, and I can't remember. But if you put your email in the chat, I can email you a follow-up.
Okay, Larry, you've had your hand up for a while. You've got a question in the chat. Do you want to ask your question?
Yes, it was from Conversations on Quora. One of the other people there who published a lot on that website about COVID and coronavirus. He was looking for a way to spot the hot spots on a city level. And I had an answer for the United States, because I could go to COVID Act now and just sort by metro. You're downloading data from the Johns Hopkins data set, right?
Yeah.
So is it possible to download that?
Yeah. It's the smallest subdivision is county.
Well, that's for the United States.
Yeah, for the U.S.
Is there something similar for the world?
Yeah, so for some of the countries, they have it by, like Australia is by province, France. For the most part, it's countrywide, with a few exceptions. Like Russia is just one number. China is by province. Australia is. But it's certainly not subdivided down to that level. Now, if you go to, as I had to do early on, if you go to France's Ministry of Public Health website, and at least for me, struggle through the French, you can get stuff by a much smaller subdivision. But I don't know of an aggregator, at least that I use, that preserves that disaggregation in the data you can get from them.
Seems like the waste stream data may be a possibility to get metropolitan level data if that becomes a more popular thing
Yeah,
globally.
it certainly is
I don't
in the
know
US. I mean, I haven't downloaded the raw data to see, but there's like 2 dots in LA. I'm not sure which the 2 dots are. But yeah.
I'm not familiar with that.
Yeah, so that's on the CDC website. They have this sewer shed monitoring where they test the effluent in the sewer for COVID, and they can estimate, at least on a relative basis, how prevalent COVID is in the population that's excreting stuff into that sewer. And in the Boston, for example, has a very detailed breakdown in their data set, but I'm not sure how the CDC keeps theirs because I haven't looked at it. I've only looked at the maps and not downloaded the data set and looked at it.
The GHU data set, is it easy to import that into like a database or a flat file or something?
Yeah, it comes, you can download a flat file, comma separated values. That's what I do from GitHub. So if you go to the nice ArcGIS interface with all the maps and stuff, in the notes, it'll point you to the GitHub site where you can access the data directly.
I knew it was there, but I hadn't looked at how it was structured.
Yeah, it's pretty easy. I mean, there's APIs and stuff if you're fancy. I just copy it and download it. Yeah.
Question here, other than the CDC, where do you go for peer-reviewed papers done globally?
Yeah, I mean, I usually just follow links around until I come to a journal I've heard of, Journal of Infectious Diseases, or I don't know that I really have a particular site, but that was my follow-up. So if anybody wants me to go back, because I have all the papers that I've downloaded and stuff, and I can go through which of those sites are useful in my experience, and I can email that.
Okay, so
In terms of the immunosuppressed, just by chance, I went to the 50th medical school reunion I had at Hopkins in the spring, and a guy named Dori Sergev gave a talk there about immunosuppressed. And so what he was doing is he was taking people that had kidney transplants and other transplants, and then they were on immunosuppressant medicines and seeing what happens when they got the immunization. Because this wasn't studied before. And what happened is if you got 2 doses, an awful lot of them had no antibodies to it. So he recommended getting a 3rd dose, and that changed the recommendation. And a lot of them tested positive after that. And however, that isn't the only thing, because there are different changes in B cells and T cells that have to do with our immunity. So the thing that they measure on the blood antibodies isn't exactly the same. And anyway, so then what he suggested doing is getting for those people, getting a booster 6 months after their 3rd one. And then I was asking him, I have some relatives who are immunosuppressed, but not with transplants. And he was saying, well, they're a little different. And he referred me to another researcher there. And what they were doing is, particularly if people are on TNF inhibitors, which is one of the immunosuppressant medicines that puts them at a higher risk. And if they have more than one other risk factor, diabetes, obesity, even age over 65, they were recommending they get autoantibody infusions. And that's called Evusheld, EVUSHELD. And they recommend having those every 6 months for right now. At least that's what they told me.
Wow.
EVUSHELD, like this?
No, I think it's EVUSHELD, Evusheld. And it's the 2 antibodies that they're giving. And so I called Dave Fisk, who's one of the infectious disease guys here in town, and he agreed with that. But he said that there is some question that it may not work as well against the Omicron as it is against the other things. But so there aren't much in the way of side effects from it. So he still was in favor of it. But if anybody's immunosuppressed, I would check with their doctor and find out, particularly if they're on a TNF inhibitor. Humira is one of them, but there are several others. But if you're on those medicines, it puts you at greater risk.
Great.
Great. Thanks, Tim.
My pleasure.
Any other comments or questions?
I think Judy Fontana has her hand up.
Oh, sorry, Judy.
Yeah, in regard to monitoring the sewage, they've gotten it down to on college campuses where they actually could tell what particular dormitories were having, could tell ahead of time where the outbreaks were going to be. And it just comes down to a matter of resources. I mean, we can pinpoint it down to that level, and it's simply resources that limit us at this point.
Sarah asked to please restate about Humira. Tim?
What was that again?
Sarah was saying, can you say again what you said about Humira?
People who are on Humira or other medicines like it, they're called TNF inhibitors. Those medicines put you at more increased risk. But he said there are other immunosuppressants that do also. And so, if you have that illness that's in that kind, and you ought to talk with your doctor about it.
Great. Thanks.
And then that would be the people they recommend getting the infusions. Wasn't just everybody in that situation. Is if you, for instance, suppose you were perfectly healthy and you were 45, they wouldn't. If you're over 65, or if you had obesity, diabetes, or inflammatory lung disease or something like that, these various other risk factors, they would recommend it, but not for everybody.
Is there an article that was written about this, or this was just your
This is just email communication.
your personal contacts?
Yeah, because they're doing the research right now at Hopkins, and they haven't got the finals on it yet. There have been some preliminary studies that support it, but they're it's just not far enough along the line yet.
Okay, great. Thank you. Judy, again?
Yeah, any of those things that they refer to in the ads as large biologicals are the ones who fall into the same category. And there are a lot of people who are on them for the psoriatic arthritis, for any of those kinds of things. So there's quite a few people out there who don't even realize that what they're on are immunosuppressants. And there's any of the arthritis medications, anyway, and things that are referred to as large biologicals.
As Sarah is saying, does that include any behavior? Is there any behavioral guidance for those people who are on those type of biologicals? Are there any different rules for them or recommendations? They just got to be extra careful, I guess.
Well, everybody ought to be extra careful, but I don't think they would do anything differently, though.
Okay. All right. All right, Dave, thank you again for all the work you put in to this month in and month out. We appreciate it. And any other questions or comments? Otherwise, we'll see everybody. Another month? What do you think?
In a month, yeah. No, just taking 2 months off is. January was vacation month, so now I should be back in March. Yeah.
All right, great.
Judy, I want to know, was the concert worth it?
Oh gosh, it was great. It was alternative rock. It was some of our favorite bands. Yeah, we were standing up, we were singing with our masks on, but yeah, I mean, and I had such mild symptoms. It's like I don't even know if I would notice it, except I was really paying attention because I was worried about it. I didn't get a fever, a little bit of a sore throat. 1 Tylenol every 6 hours for 2 days was enough. It was exceedingly mild. I was very fortunate. But maybe once next year when I'm 65, when I get into that 65 and older group, then maybe it'll be different.
One of the things I was interested in is reading some of the things in the paper about the Santa Barbara County Jail. So I think they test everybody, and about 20% of them are positive, but only 20% of them have, of those that are positive, only 20% have symptoms. So there's tons of people out there who have it who don't know it.
Mm-hmm.
Yeah.
I can believe that from the mildness of my symptoms. If I hadn't been at that concert and was really paying attention, I don't know if I would have noticed it.
I went to a concert also. It was that super concert in New York in August. I don't know if you guys heard of it or not, but everyone was unmasked. It was outdoors in Central Park, and it was amazing.
Can I ask one more? Do you guys mind? Sorry about that. I have a poor connection.
No, go ahead, Sarah.
Putting in the chat. I was wondering for those who know about the biologics and the immunosuppressant medications. So the medications that are being used to, I don't want to say treat COVID, but I guess treat the symptoms of COVID. or medications that doctors are giving COVID patients, are those compatible with biologicals? And I'm curious to the group if you guys have any like knowledge about those medications specifically that you could share. And also, this is maybe one more for Dave, but for anything about long COVID that you could share from your findings, specifically for like immunocompromised populations, or just like future variants that you might, that you think that you predict, or I guess really this question for anyone, but even if we're preventing hospitalization through vaccination, what about like how will society compensate for the long-term COVID issues affecting our population, like more chronic illness? Thank you.
Yeah, those are great questions. I don't know if I really have an answer to many of them. I mean, I think there are treatments that treat COVID, and then there are treatments that treat symptoms, both. And the ones that, at least the ones I'm aware of that treat COVID themselves, are things that treat it like your immune response. So, but I mean, I'm not in a position to say, well, yeah, if you have this condition, you can take this, or you shouldn't take this. And in terms of long COVID, I haven't really found data on, outcomes other than recover or fatality. But in terms of the duration of the disease, or the these other kind of intermediate outcomes, other than the ultimate outcome of either recovering or not, I haven't been able to find data on that. So I don't have any idea which, by variant, by place, by anything, because I haven't found the response data that corresponds to long COVID.
What are your
Okay.
thoughts about compensation by society for getting COVID?
Yeah, I don't know. I think I don't know that I necessarily have an opinion on that.
Kind of getting outside of your wheelhouse here a little bit. I can see.
Yeah,
you're
no, I'm
uncomfortable.
thinking about. Well, I mean, because I'm thinking about, there's some sentiment that, well, man, if you, for whatever reason, you didn't get vaccinated, and so you got really sick, the sympathy the sympathy for that situation, I think, is thin. And so, but then at the same time, you can't say, well, like, if you did everything right and you still got COVID, then you get compensated. I mean, it is an exceptional instance of the disease, but it's a common thing, right? People get sick, people get cancer and have to go off and get treated and come back and everything. I would think if we're going to address that, my thought would be to address it more holistically rather than just focused on COVID. It is an extraordinary couple of years of disruption, but I would think something like a compensation policy for illness would be something that would have to be more comprehensive than just COVID.
Yeah, I don't think society compensates for cancer. I mean, we just help you fight cancer. Your compensation is survival.
Yeah.
All right. Well, thanks again, Dave.